Hello, friends. Welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and in today's session, we'll be having two case scenarios to discuss regarding genital tract hematomas, which form an important differential diagnosis of women presenting with hemodynamic instability or shock after delivery. And my referral code here I have highlighted, which is SHONALI. So you can use this code to avail a 10% discount on your subscription package from the Unacademy platform. You can also download the Unacademy learning app on your mobile phones now and get notified about the upcoming special classes, upcoming crash courses, batch courses. On the platform, you'll get daily live classes where you can chat with your educator, ask your doubts and queries, and get them solved there and then, all the while that the class is going on. So it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes getting conducted regularly on the platform, so you can evaluate your performance as you go along your preparation. And most importantly, one-time subscription gives you an unlimited access. So once you subscribe to the platform, you can watch all the sessions, all the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform. All 19 subjects which we need to prepare for our post-grad entrance examinations, they are covered. And every now and then, comprehensive batch courses as well as short duration crash courses, they keep getting launched. So giving an example of the recent, courses that have been launched on the platform. So there's a focus batch for particularly FMGE. It's a short duration crash course there, which started on the month of February. There's a last mile to crack NEET PG 2021, again a crash course. And there are also batch courses, like there's a Target Next 2022 batch. There are evening batches as well as there are morning batches. So you can choose a subscription package depending on your needs and requirements. And now you can also subscribe to the Iconic platform, which allows you to access Unacademy and Prep Ladder at the same time. Now you can choose this Iconic platform for 12, 18, 24, or 36 months duration. And if you subscribe using my code, you can avail a 10% discount on your subscription package as well. And talking about the various NEET PG plus subscriptions which are available, again, you can choose one depending on your needs and requirements. So, for those of you who are targeting the upcoming NEET PG, which is scheduled in April 2021, you can take the shorter duration 1 or 3 month duration course for a crash course. For those of you who are targeting the next exam, they can take the longer duration package like 12 months. It will give you ample time to go through all of the sessions and will also leave you enough time in the end to revise. And as you can see, on a monthly basis, it turns out to be more economical also. And for those of you who are in your third year or final year MBBS, they've started preparing, or you're simultaneously working and you're preparing, so you want a slower pace of preparation, you can take the 24 months duration package. It turns out to be far more economical in the longer run. And if you subscribe using my code, then you can avail a 10% discount on your subscription package as well. While you're on the platform, you can check out the special classes that I've taken previously on the platform in the last couple of months. You can also get access to the various capsule courses, like there's a capsule course on high risk pregnancy, gynae oncology, clinical situations in early pregnancy, labor and its complications, a complete capsule course on reproductive gynecology. So these are all capsule courses which will be available once you subscribe to the Plus platform, and you can use my referral code to subscribe and avail a 10% discount on your subscription package there. So coming back to the session at hand for today, let's see here. We have Deepika, good evening. Mehboob and Baha, good evening. Uttam, good evening to you too. So welcome everybody. So yesterday's session we talked particularly about atonic PPH. We defined what PPH is. It is blood loss after delivery. Now see, the blood loss after delivery can take a variety of forms. Something that is visible as a gush of blood flow through the vagina. That means, you have the blood flow coming from the uterus or from the cervical or vaginal tears or episiotomy site. It would be clinically visible to you, right? But when you say hematomas refer to collection of blood. right? So then in that situation, you might not have a visible blood loss, but yet your woman would be showing features of shock because she's losing blood somewhere, isn't it? So let's talk about the genital tract hematomas. And Ervizidi, good evening to you too. So what are the kind of various types of genital hematomas that we know of? So we can have the vulval hematomas, like you can see here, blood collection here in that space in the superficial and the deep perineal pouches, right? So you can have this vulval hematomas, which will be evident clinically on local examination. As you can see, it will be a swelling on the vulva, and it happens because of the involvement of the arteries. It can be traumatic rupture of the arteries which can take place, or laceration of the branches of pudendal arteries, or there might have been an episiotomy incision and these branches of pudendal arteries have been cut, or there have been a genital laceration and these arteries have become involved in that laceration. So which vulval hematomas result because of involvement of branches of pudendal arteries or bleeding from these pudendal arteries into this enclosed space here, right? Now, on the other hand, you can also have paravaginal hematomas. Now, what are these paravaginal hematomas? Now, paravaginal hematomas are going to be here in the vagina. It is around the vagina, so they're going to bulge into the vagina. So they can be here. There can be a hematoma in this space, or there might be a hematoma in this space. It can be above or below the levator ani muscle, that doesn't matter, supralevator or infralevator. But actually it is going to bulge out into the vagina, and the arteries that are involved in the formation of paravaginal hematomas. That's another direct MCQ that they ask of you in your examination, right? So for the vulval hematomas, the branches are branches of pudendal arteries, and for paravaginal hematomas, the branches are, which arteries are involved? Branches of vaginal artery are involved, or maybe branches of the descending cervical artery are involved, right? So your descending cervical artery, you see your uterine artery is here, which is entering the uterus on the sides. From there it gives an ascending branch, from there it gives a descending branch. Now the descending branch supplies the cervix, supplies the upper part of the vagina. So any of these branches of vaginal artery, or descending cervical artery branches, which in turn is a branch of uterine artery, could be involved in the process of formation of paravaginal hematomas, right? And other than this, there can be a third type of hematoma which you should be knowing here. Let's see. Anybody answering what could be the third type of hematoma there? So let me just draw this uterus back for you guys here. So that's your uterus here, and that's here is all the broad ligament, right? So there can be a collection of blood, on the side of the uterus, right, in the leaves of the broad ligament. So this becomes a broad ligament hematoma here, becomes a broad ligament hematoma. This is going to be collection of blood on the side of the uterus, adjacent to the uterus. Okay, now this could be small, this could be large, depending upon how much blood has collected in this space. All right, and how is the broad ligament hematoma going to be formed? Now, how the blood get collected into this space in the leaves of the broad ligament? There could have been a cervical laceration, which is ascending upwards, or there could have been a uterine tear, which is ascending, which is transcending the uterine cavity, right? So there can be deep cervical lacerations, which are extending upwards towards the lower uterine segment. Here, from here till here, they are going upwards, some lacerations, some trauma that occurred during delivery. Or there could be a rupture of the lateral aspect, particularly the lateral aspect of the lower uterine segment, which has resulted in collection of blood in the leaves of the broad ligament, right? So please be wary of this finding also. There can be a broad ligament hematoma also forming under conditions of maybe a cervical laceration extending upwards into the lower uterine segment, or a rupture of the lateral aspect of the lower uterine segment as well. Now, it is important to note in all of these hematomas is that the visible bleeding will not be much, right? So, all of these hematomas are actually leading to blood loss. But please remember that this blood loss is not clinically visible. However, since the woman is losing blood, she might be having varying degrees of hemodynamic instability. She might be going into shock, she might be having severe pallor, right? Now, how are we going to suspect? So we are going to suspect when a woman is presenting features of shock, or sometimes you see the paravaginal hematomas and the vulval hematomas, right? These hematomas in the lower genital tract, they are going to cause intense pain in the perineum. A woman is going to complain of intense pain in the perineum. And sometimes these hematomas can be large enough, you see, to compress the urethra in the front. Then a woman may also be complaining of inability to pass urine because of compression of the urethra in the front. A large sized hematoma could compress the urethra as well. So that could be another clinical feature. So please remember this important point as well, right? And a woman who is presenting with the broad ligament hematoma, on the other hand, would have features of hemodynamic instability. She will not have, intense pain in the perineum or inability to pass urine, but she could definitely complain of pain abdomen, right? She could definitely complain of pain abdomen, severe pain abdomen, which is out of proportion of a usual pain abdomen, which happens to women after delivery, which we call as the after pains of uterine contractions. Okay, so this is about revision of the various types of genital hematomas which we can encounter. Now let's go forward and talk about the first clinical case scenario here. Now, there's a primary gravidae, friends, who had a forceps vaginal delivery at 9 p.m., right, after a prolonged second stage of labor. The birth weight of the baby is 4.2 kgs. Episiotomy was there, a lateral vaginal tear was also there. You see, instrumental delivery, big size baby, but they were sutured. At around 1 a.m., she complained of severe pain in the perineum, so much so that she is unable to sit. You see, women generally have pain in that stitch line or the site, after episiotomy, but she's complaining of severe pain so much so that she's even unable to sit. There is no response to analgesics. You've given her pain relief medication. She's not relieved of her pain. She has not yet passed urine. That's your second clue. There is no complaint of excessive bleeding also. That's your third clue. Now, my question to you is, can you identify the risk factors for the formation of a genital tract hematoma in this particular case scenario? Can you identify the risk factors in this case which will promote or which will be, causing a genital tract hematoma? Anybody? What are the risk factors for genital tract hematoma formation in this particular case? Instrumental delivery, isn't it? Prolonged second stage of labor. Prolonged labor of any kind, prolonged first stage, prolonged second stage. Now that also leads to the risk factor for having a vaginal hematoma. Birth weight of the baby, big size baby, that is also a risk factor. The fact that there was an episiotomy and there was a lateral vaginal tear also, maybe while we were suturing the episiotomy or while we were suturing the lateral vaginal tear, we failed to achieve a proper hemostasis, and then at a later point in time it resulted in a hematoma formation. So all of these highlighted points that I've given you here are the risk factors for genital tract hematoma. And Mehboob rightly said even obstructed labor. A woman who has been in obstructed labor for a long duration of time can later on develop a genital tract hematoma as well. So risk factors are perineal tears, Nulliparous woman in this particular case, she's a primigravida. Nulliparity, the perineum is much more tighter for somebody who's delivering for the first time, therefore more risk of having a genital tract trauma. Big baby, right? Even multiple pregnancy is a risk factor for multiple pregnancy undergoing a vaginal delivery, right? And prolonged labor, instrumental delivery, these are risk factors. And certain other also risk factors to add to the list would be a coagulopathy, clotting disorders. If a woman is having a clotting disorder, then of course it can result in excessive bleeding and hematoma formation, right? So these are the risk factors of this situation. Right? Now let's go ahead and talk about the important points to note in the examination of this particular woman. First of all, you have to notice and establish her hemodynamic stability or not to know how decompensated she is. So you need to check her general condition, pallor, pulse rate, BP, respiratory rate. You have to check a note of the urine output. Has she passed urine or not passed urine? That you have to note. On per abdominal examination, you have to note whether the uterus is contracted or not to differentiate it from atonic uterus. In a woman who is presenting with shock, you see, very, very important to differentiate atonic uterus because it's the most common cause of shock after delivery. So you should note whether the uterus is contracted or not. You should note if there is a mass you can palpate in relation to the uterus, in adjacent to the uterus, right? You should note if there is a suprapubic bulge. If there is a suprapubic bulge, what would it point to? It would point towards urine getting retained, right? It would mean a full bladder. The suprapubic bulge would mean a full bladder because she has been unable to pass urine, right? So please note that also. And on local examination, a lot of things can get cleared because if you have a vulval hematoma, you will be able to see it. If you have a vulval hematoma, you will be able to see it as a swelling on the vulva, right? And even if you're not able to see a vulval hematoma and you're suspecting a genital tract hematoma, do a thorough pelvic examination, you see. Do a thorough pelvic examination in each and every of this case so that you can feel or see the vaginal hematomas, right? Make sure that you do that also. Pheoceal genital hematomas. And you should also do a pelvic examination. In that, you should do a thorough cervical exploration. And vaginal exploration. You should be seeing yourself if there is any genital tract trauma there. You should rule out any lacerations on the cervix or the vagina which could be responsible for her excessive bleeding. But in our case, there was no excessive bleeding. Clear? So let's see what we found in our case. There was a woman who had 4 hours postpartum we were seeing her. So 9 p.m. she had delivered, 1 a.m. she had complaint of severe pain in the perineum with all the high risk factors in her history for hematoma formation. She was extremely pale, her pulse rate was 120, her BP was 100/70, she was hemodynamically unstable, she was having features of shock also. Right? Then we did a per abdominal examination. On that, we found that the uterus is well contracted. There is no tenderness per abdomen. The abdomen is soft, so there is no problem. There is no collection of blood aside, adjacent to the uterus. The uterus itself is well contracted, so it's not like she's having atonic PPH because, shock after delivery. You should always be suspicious of postpartum hemorrhage. Okay, maybe she's losing blood from her vagina. Maybe there is atonic uterus. So you should always suspect that. Therefore, doing per abdominal examination is so important. On local examination, you find that there is a vulval swelling at the region of episiotomy, where you had given your episiotomy. There is a vulval swelling of size around 8 centimeter. It is tense and tender like this. Okay, and please, that always, even when you see a vaginal, a vulval swelling, do a PV examination must, do a cervical exploration must. No other laceration in the vagina or vulva are found apart from this hematoma. On PV examination, there is no fornicial tenderness or fullness, right? So why are we seeing this PV and we are seeing that there is no fornicial tenderness or fullness? That means there is no collection of blood in the pelvis. That means there is no collection of blood in the pelvis, because if there is a broad ligament hematoma and if it's huge in size, it could be tipped from below while we are doing a PV examination. So your clinical diagnosis has been based how? On performing a clinical examination, you found out that the woman is in shock, right? When you found that the woman is in shock, you quickly rule out whether there is atonic uterus. You found that the uterus is well contracted. You did a local examination. You found that there's a swelling on the vulva. There is no other laceration vagina or anywhere else in the cervix, right? So your diagnosis is a vulval hematoma. Your diagnosis is a vulval hematoma, right? Now, the next question that arises is, how are you going to proceed in this particular case scenario? So you have to focus on the maintaining the hemodynamic stability of the woman. So your primary focus has to be to inform a senior roll call first. Okay, because you have to think ahead, right? So you cannot be managing as an intern or as an MBBS graduate. Always inform your senior person on call. Send for the urgent blood investigations, blood grouping, blood grouping, RH typing, cross matching, right? And since she is in shock, you need to send her CBC also. You need to send her coagulation profile also, right? And she's been unable to pass urine, she's in shock, send a baseline renal function test also, right? So manage the shock simultaneously. Begin your resuscitation with IV fluids, and the protocols of IV fluid resuscitation are the same that we discussed yesterday in atonic PPH, you see. So you have to give her IV fluids, you have to give her warm crystalloids. So manage her shock like you would in any patient of shock, right? And after that, you also catheterize her bladder, isn't it? She's in shock, she's unable to pass urine. You catheterize her bladder and keep the catheter in place, because later on you'll monitor an input output also. And finally, as far as the treatment of hematoma is concerned, you have to drain that hematoma, right? Now, drainage of that hematoma has to be done in the OT, right? In the OT under anesthesia, right? Under anesthesia, you will have to do it. You will have to have the lighting of the OT. The patient position can be made in the OT. She will be more cooperative. You have to do it under anesthesia. That's why you have to do it in the OT. You cannot do it in the labor room. And since you are putting a surgical intervention in place, you also have to do it under antibiotic cover, right? So now when you have a hematoma there on the vulva, you're going to give an incision over that hematoma, right? Once you open that up, you are going to find clots collected in that hematoma, organized clots. You are going to evacuate all those clots, right? Now there is going to be that bleeder, that spurter, that vessel that is oozing blood, and you have to identify that. You have to seal it off, right? So you have to ligate the bleeder, and we often prefer to give a figure of 8 stitch. Figure of 8 stitch, so that we securely ligate that bleeding vessel, that bleeding sprouter, that whatever you might call it, that bleeder, that spurter. So you ligate it, ensure that you tie it, and then you close the dead space, right? And obviously, whatever the woman has lost in that space, whatever blood she has been lost, blood has to be replaced by blood. You see, so in that organized space, in that hematoma, she could have lost 800,000, who knows how much ml of blood she has lost there. So you will guide your decision by doing the complete blood count, right? And then you have to, at a later point in time, also you've started the resuscitation, but replace blood by blood. The same protocol will be followed. So you will give her blood transfusion as well. So this is how you are going to have a clinical presentation of genital tract hematomas, right? A woman would be in shock after delivery. When a woman is in shock after delivery, always think it could be atonic PPH. In that case, the uterus is going to be relaxed. In a case of hematoma, your uterus is going to be contracted and there will be no visible blood loss significant, right? You will have collection of blood in the spaces. So she will have shock which is out of proportion to the visible blood loss. And then simple clinical examination, local examination, a PV examination, a per abdominal examination will make your diagnosis. And the management will be simultaneous resuscitation and drainage of the hematoma in OT under antibiotic cover. Now this was the first case scenario. Now let's have a look at the second case scenario, which is slightly more interesting there for you. So let's see here. There's a multiparous woman who's been referred from the PHC, Peripheral Healthcare Center, where she delivered, and she's been referred in shock. So you are the intern, you are the you are the MBBS graduate who is manning the emergency there, and you see a multiparous woman being wheeled into the casualty. She's been referred from a peripheral health care center. She's in shock. She, after undergoing a difficult vaginal delivery 4 hours ago. So that kind of history you quickly get. You say, kahan se aaye, where this patient has been brought from. They tell you she's been brought from PHC. She delivered 4 hours ago. She had collapsed right after she got up to pass urine. Now that's also the kind of history that you get. That, the moment she got up to pass urine, she just collapsed right there, right? So collapse, postpartum collapse, right? Postpartum collapse, postpartum shock. What could be the differential diagnosis? What could be the differential diagnosis? Now we're discussing a genital tract hematoma. I agree that is your first differential diagnosis. But also, what could be the other possible causes of postpartum shock and collapse? Guys, yes, anybody taking a dig at that? What could be the various differential diagnoses here? What is coming to your mind? What happened to her? She's in shock, referred from a peripheral healthcare center. 4 hours ago she had delivered. What could be the differential diagnosis? She could be having an atonic PPH or traumatic PPH. She must have bled en route a lot. She must have bled en route. She must have bled in that PHC, right? Who knows how that atonic PPH was managed? There may be a traumatic PPH. There is a difficult vaginal delivery. There might have been a vaginal laceration, a cervical laceration. Who knows? So she could have been any of these scenarios. There could have been a genital tract hematoma, right? Mehboob, acute kidney injury. Okay, I would say acute kidney injury secondary to hypovolemic shock. I could give that to you also, Mehboob. That could be a possibility, but look for more common causes. Acute kidney injury probably has resulted as a consequence of hypovolemic shock rather than causing shock, you see. So I will not include it in the differential diagnosis. Then there could be inversion of uterus. She was being delivered in a PHC by, I don't know who, maybe some trained birth attendant, or was it an untrained birth attendant? I don't know who was delivering. Possibly could have had an inversion of uterus, right? She's a multiparous woman. She had collapsed right after delivery. Who knows how difficult her vaginal deliveries, could have had a rupture uterus, who knows, right? So these are your differential diagnoses. And finally, yes, of course, another differential diagnosis which should be on your mind, which is often a diagnosis of exclusion, is amniotic fluid embolism, right? So it is a diagnosis of exclusion when there is no way to explain a woman's collapse or shock after delivery. When you have excluded all of the possibilities, you come to a diagnosis of exclusion, which is amniotic fluid embolism. So these are the various differential diagnoses. And how do you come to differentiate them? You take a history from, if the patient is able to give the history, if she's conscious, you'll take it from her. Otherwise, you will question the people who brought her into the PHC, right? It could be a staff attendant, it could be a doctor who has brought her. You take that history from her, from that person, or there could be a relative who is ready to give you that history. And very often, when a patient is always referred, they have a referral slip, and information about the patient's referral should be noted in that referral slip. So you read a referral slip, and it tells you that her referral slip states that she was immediately started on IV fluids and oxytocin drip. Fine. Vaginal bleeding was not excessive. There was no episiotomy or perineal tear. So this is the only bit of information that the referral slip provides you. I will say that it's a very bad referral slip. It's an incomplete referral slip. Doesn't give me much information. So I have to examine the woman myself. However, because there is a history of vaginal bleeding not being excessive, I would say atonic PPH and traumatic PPH are less likely, because in these situations the vaginal bleeding would be evident, right? Visible bleeding would be there. In atonic PPH, your uterus in turn would be flabby, right? I would think of hematoma still, right? Hematoma, the visible bleeding would be normal, right? In inversion of uterus, when the uterus inverts, what's inversion of uterus? This is inversion of uterus. If your uterus has inverted on top of itself, obviously, only an atonic uterus can invert a uterus which is relaxed. And after that, inversion of uterus is usually followed by hemorrhage. So, of course, in inversion of uterus also, your bleeding would be more, right? In a case of rupture uterus also, your bleeding would be more, vaginal bleeding would be more. And more so in a case of rupture uterus, she would have other clinical characteristics, right? So we're going to talk about how we examine a woman who's come in this collapse state, who's come in shock. We don't know anything about her. Let's see. On examination, what did we find out? On examination, she looks extremely pale. Pulse rate is 130, BP 80/50, respiratory rate 30 per minute. The chest is clear so far, so good, right? Fine. So she is in shock, deteriorating by the minute. Per abdomen examination, there is no distension. Uterus is just below the umbilicus, well contracted, deviated to the right side. Let me tell you more. On local examination, there is no vulval swelling. There is no vaginal bleeding. Per speculum examination I did, no vaginal laceration I found, no swelling in the vagina I found, no cervical tear I found, no bleeding from the os I found. On PV examination, there is fullness or bogginess which is felt through the vaginal fornices. Now, this is my list of differential diagnosis which I have to consider. Uterus atonic, not likely, as the uterus is well contracted, isn't it? Uterus is well contracted and there is no vaginal bleeding even right now. Neither was there history of vaginal bleeding in the referral slip. So, uterus atonic, ruled out, right? And let's say amniotic fluid embolism, it has to be a diagnosis of exclusion. Moreover, in a case of amniotic fluid embolism, the presentation is much more drastic. A woman presents with cardiorespiratory compromise, right? So a woman presents more with immediate breathlessness after delivery, and there is rapid clinical deterioration. And this cardiorespiratory compromise, because of that pulmonary embolism which has resulted because of amniotic fluid, it will immediately lead to pulmonary embolism like features, sudden onset breathlessness. Then a woman goes into cardiogenic shock, and later on there is DIC and hemorrhagic shock. Later on there is DIC and hemorrhagic shock. So bleeding would be more in amniotic fluid embolism also. So I'll not consider that as the differential diagnosis, right? Now, if there had been inversion of uterus, what would have been here? If there had been inversion of uterus, the uterus should not be felt per abdomen. If your uterus has inverted like this, then uterus cannot be felt just below the umbilicus, right? It cannot be well contracted. isn't it? So, inversion of uterus is also less likely, and there should be vaginal bleeding, isn't it? There should be excessive bleeding from this uterus. Excessive bleeding from this uterus should be there, but that's not there. So, I will rule out the possibility of inversion of uterus. Now, my two differentials are, which are still left, is a genital tract hematoma and a rupture uterus. Okay, so it could be a genital tract hematoma. Do you agree? The uterus is well contracted, deviated to one side. Okay, why is it deviated to one side? Because maybe there is a collection of blood adjacent to the uterus. That's why it is deviated to one side, right? And on PV examination, what am I feeling? I'm feeling this fullness or bogginess through the left vaginal fornix. So I'm feeling it on the left side, and the uterus is deviated to the right side. There is possibly some collection here. So my suspicion is, based on this clinical profile, is probably, very good Lucas here, a genital tract hematoma. It could be a broad ligament hematoma. Could be a broad ligament hematoma. But it could also be a rupture uterus. Couldn't it be a rupture uterus? A rupture uterus which has led to collection of blood in the pelvis? It could be a rupture uterus also. Could be a rupture uterus as well. How do I find out? How do I find out? Or let's say, how do I proceed in this case? How do I proceed in this case? How do you proceed? When you proceed, you have two situations to take care for. Make a diagnosis, and other is resuscitation. Other is resuscitation. She's losing blood, she's in shock. You have to make a diagnosis so that you can take care of the bleeding. So that you can take care of the bleeding. So her management would be resuscitation along the lines of management of hemorrhagic shock. You have to have resuscitation of this hemorrhagic slash hypovolemic shock. Plus, I will go for an urgent laparotomy. I would go for an urgent laparotomy. I will open her up and see. And on opening up her and seeing it, I will find either a broad ligament hematoma. I will evacuate that hematoma, right? And I will also find the source of bleeding for that hematoma, right? So that source of bleeding has to be identified and ligated, right? Now that will be done. And if I find a rupture uterus, if you find a rupture uterus intraoperatively, if you find a tear in the uterus, if you find a tear in the lower uterine segment, that has to be sutured, that has to be stitched and repaired, actually stitched, sutured, repaired, right? So that is what you will do on laparotomy, right? So you will identify the source of bleeding, you will secure it, ligate it. If there's a rupture uterus, you're going to repair that rupture uterus. And all the while, you're going to replace blood by blood. So this is the management of this acute situation which you can encounter in your emergency departments. A postpartum woman coming with shock and collapse, right? So please remember these important differential diagnosis, right? So when you are under reading genital tract hematoma, a woman can have a variety of clinical presentations. It can be a clinically evident situation where a woman is not so much, she's not hemodynamically unstable. She might just complain of pain in the perineum, and she might just complain of inability to pass urine. Then you suspect a genital tract hematoma. Or there is a possibility of having an acute presentation like this, where she's been referred from some place, or she's been left unattended after delivery, only at a later point in time for you to discover that that woman has ended up in shock. And then you have to consider all the possible differential diagnosis of genital tract hematoma or shock after delivery, right? And Lastly, I just want to say here that in these two case scenarios, especially in the first case scenario I discussed with you, I told you that drainage of hematoma is what is to be done. Now, conservative management of a hematoma can also be done, just waiting and watching, giving pain relief, cold compresses. I mean, that can also be done, but only as long as the woman is stable, only as long as the woman is stable and she has a hematoma whose size is less than 5 centimeter. Size less than 5 centimeters of the hematoma, and that hematoma should be decreasing in size, on observation. Okay, only then you can manage a hematoma conservatively. And please note that she should not be having severe symptoms. She should not be having severe pain. She should not be having inability to pass urine. So if severe symptoms are absent, then only you can do conservative management for a hematoma. Otherwise, if a woman is unstable, if a hematoma is more than 5 centimeter, you're trying to observe it but it is increasing in size, or she's complaining of severe pain, she's unable to pass urine, such severe symptoms are there, then you have to drain that hematoma immediately. Okay, so this is about the management of genital tract hematomas. So any doubts and any queries in this session, guys? Any doubts, any queries in this session, guys? Hello, Stanley. Good evening. And in tomorrow's session now on YouTube, same time 4 p.m. So Sadia, live classes timing and days of YouTube. The days of YouTube are almost every day except for certain days where I take a break. Otherwise, there are almost regular classes on YouTube, and every day on YouTube the timing is same 4 p.m. Okay, so tomorrow on YouTube, I will be taking up a case scenario of acute uterine inversion. That is going to be the case scenario for tomorrow, guys. Acute uterine inversion is what I'm going to discuss in tomorrow's session. Again, we are going to consider the differential diagnosis. We're going to consider the diagnosis of acute uterine inversion, how to manage acute uterine inversion. So that is going to be the topic for discussion tomorrow's Farah and Sadia, same time 4 p.m. Okay, and there are various capsule courses, detailed theoretical courses on the Plus platform. You can also access them, but for that you'll have to subscribe to the Plus platform, and you can use my referral code to avail a 10% discount on your subscription packages. And like I explained in the beginning of the session, there are various modules of subscription. You can choose one depending on your needs and requirements as well. And please feel free to offer me any kind of suggestions regarding the topics that you need covered, anything that I'm missing out, you feel that you need to be discussed, please put it on the chat box. I'll be more than glad to come up with new videos on the platform, guys. So thank you so much for watching. And if there are no further questions, I'll end the session for today. So have a great day. Thank you so much, guys. And I'll see you tomorrow, same time, 4 p.m. to discuss the case scenario on acute uterine inversion. So we touched upon acute uterine inversion as a differential diagnosis for a woman in collapse. I'm going to elaborate on it further tomorrow at 4 p.m. Right, so Sadia, obstetric transfusions, all right, I will take that up also. I like that suggestion. One can have a session on that as well. So thank you so much, guys. Have a great day. Take care.